Hello and a very warm welcome to all our attendees today. And today's webinar is Talking Confidently about Sex and Sexuality with Your Clients, which is an often overlooked area of our clients' health and quality of life. And it's an area, obviously, we do need to be able to confidently converse about. I'm really delighted today. We've got Dr. Margaret Redelman as our presenter today, and I'm your facilitator, Nicola Graham. So we start all our programs with an acknowledgement. So we acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and respect the cultural authority of elders in each community. Now, we're very privileged to have Dr. Margaret Redelman presenting for us today. Dr. Redelman is a GP. She has an Order of Australia, and we had a few audio technical difficulties earlier on, and I think she should receive another Order of Australia for her patience with me earlier. Margaret has a master's in psychotherapy, and she trained in sexuality in the USA. She works as a sex therapist and a relationship therapist in private practice in Sydney. She's published papers on the topic, has held numerous executive roles in the sexual health field, including she's on the executive committee of the SAS, Society for Australian Sexologists. She was past president of the SAS New South Wales, past president of the Asia Oceania Federation for Sexology, and president and convener of numerous conferences. So a very warm welcome to Margaret today. Just a note there around informed choice, and I'm now just going to switch my webcam off and hand over to Margaret. So just bear with us.
So I can start?
Yes, thank you.
Well, hello everyone and welcome, and thank you very much for attending. I'm obviously quite passionate about sexuality, and people quite often wonder why a normal person would become a sexologist. And it's, all I can say, it's a wonderful career choice that gives me the privilege of listening to people's most private thoughts. And it is a privilege and a very enjoyable one. The other thing I'm passionate about is people who deal with intimate issues, which is quite stressful at times, and can be chronic illness, it can be disaster work, it can be sexuality, need to look after themselves. So what I'm sharing here with you is one of my personal hobbies, and I carve wood and these beautiful, delightful female forms. So I would encourage each of you to look after yourselves and to have a hobby. Now, you're all attending this meeting wanting to be more helpful for your patients or clients. And sexuality is a little bit different from blood pressure or nerve damage. It's more personal. And we're often very confused about how to deal with sexuality because we live in a very sexualized society that has very unrealistic norms, values about what's normal. And we generally have a very poor sexuality education. If you think about your own life experience, even if you think you had a good sexuality education, think about it. Did someone actually sit down with you and teach you, well, how to masturbate well, or how to help your partner have the best orgasm they could have? And that's what I call sexuality education. Usually what we mean is we had the chicken and egg talk, or how to not to get an STI, or how to say no more recently. So we do have a sex education program, but it's usually not a sexuality program. And because we don't get that, and we usually haven't been able to watch our parents negotiate their sex life, we have a very poor robustness or resilience when conditions change. And the conditions change if we have an accident, very simply as we get older, as our relationship lasts for a longer time, so we're no longer so new to each other. We have no resilience really, or no knowledge about how to deal with these things. So here is that confusion, and these kind of billboards don't help people be happy with their sexuality. So there's all of those issues of confusion about how to get the best for yourself and what's normal. So I'm going to cover roughly what is sexuality, why it's important, benefits of positive sexuality, some of the cultural things, why it's hard to talk about it, and how we can help ourselves and our clients to become more comfortable, and a few resources. So what I'm really hoping is that you gain a confidence in raising the topic because you strongly believe in its importance, and you start practicing your skills. You can't become a concert pianist on one lesson. So this is just a taste, an introduction. But I hope that with a strong belief that sexuality is a valid medical issue for people to address, you will start that journey of becoming better and better at it. It takes time. So what is the difference between sex and sexuality? So sex is what our genitals do. It's the erection, it's the lubrication, it's the penetration. And most of us are adequate at that. In the time, in our late teens, 20s, 30s, when nature wants us to reproduce. But in reality, when patients come to us with a sexual difficulty, it's not the sex part that's really important, it's the sexuality. And sexuality is who we are. It's how we feel about ourselves, how we relate to our partner, what it means to us in the world around us. And it requires technical knowledge and practice. It's not something that we're born with innately. We're all born with the instinct to have sex, but the quality of that sexual experience is a learned one. And that's what sex education is about. And this is my favorite comic. And as you can see, sex is perfectly natural, but not naturally perfect. So why is it important? Well, there is the biological component for reproduction, but in fact, we make love for reproductive reasons, I don't know, 0.1% of time or less. But more importantly, it's a mega communication form. It's a way of giving love, receiving love, being validated as a man, as a woman. We use it to relieve boredom. I think it's a better sleeping pill than Normasin. We also use it for reward and punishment or control in relationships. But most importantly, and recreation feels good, but most importantly, what I'd like you to remember is that human beings are just mammals. And one of the components for mammals to have wellness, emotional and physical wellness, is touch. So skin hunger needs are critically important. Infants in orphanages where they're not touched end up emotionally and intellectually retarded. Older people in nursing homes where they're not touched or hugged appear demented or depressed. And if you think about it, in that middle range, mostly people get touched during sexual activity. The Anglo-Saxon culture is not a very touchy one. You know, when we got the Italian migrants coming in past times, they brought a little bit more touch into our culture. But to a large extent, Asian cultures aren't very tactile, at least in public. And skin hunger needs mainly get met in sexual activity. If people aren't touched, it really makes every other sad aspect that's going on in their life that much worse. Being hugged is really important. If you think about it, when a child falls down and hurts themselves and the mum gives them a hug, doesn't that make the pain better? And for your patients with MS, they are having so many losses in their life already that if you can supplement, if you can maintain that tactile contact, the hugs, the kisses, the caresses, whether it's on the breasts, on the genitals, on the arms, anywhere, you are really helping that person in the overall quality of their life experience. So I'm always talking about minimizing losses for our patients. So the benefits of good sexuality are huge. They're both psychological and medical. So for the individual, it's that self-esteem. So there is that young woman who's becoming clumsy because she's losing her balance and her leg power. But if her arms are okay, she can masturbate and she can still be sexual and she can still be a good partner for her lover. So if there's a component that can maintain the self-esteem, if she doesn't withdraw from sexual activity because of those other things that are going on. So maintaining sexual competence is really important. It's a feeling of normal. I'm not losing everything. In relationship sense, you know, the chances are the partner as well. So what are they doing with their sexuality? If you can maintain good enough sexuality between the two of them, it maintains that bond. It maintains that source of support and goodwill and peace at home. And let's face it, who doesn't want peace at home? So there are often two people involved. If you have a patient with MS, you don't just have one patient, you have two people. And if you have the partner on board, then you've got a support system there that's really important. And of course, being sexual and having an orgasm releases wonderful neurotransmitters and endorphins, and it has all sorts of lovely benefits like pain amelioration, lower blood pressure. We think maybe it improves immunity, but they're all positive. I can't see anything negative in what I'm presenting here. And this is just a little bit of information. I thought there was some research that having intercourse twice a week or more correlated with a lower incidence of fatal MI. Frequent intercourse led to a better weight balance. So there are all sorts of research that has come along that, you know, points to the value of having a good enough sex life. But most importantly for the medical fraternity, it is not a frivolous side activity. Sexual function is a marker for other medical conditions. It's like the canary in the coal mine, because erectile difficulty is a warning signal about the vascular health of the individual. The penile arteries have the smallest diameter of any arteries in the body, and therefore they get affected first. And we know from research that erectile difficulty often predates a cardiovascular incident by 3 to 5 years. So it gives you a window, an opportunity to be proactive for the overall well-being of the patient. And I suspect that vaginal lubrication is also, because it's a similar physiological event, but it's more difficult to monitor. So sexual function, sentinel markers for cardiovascular disease. So it's not frivolous. There's a really valid medical reason for asking sexuality questions. So on the flip side, what do we lose if we don't have sex or we have bad sex? Because for your patients, if you think they've lost their sexual activity, then you also need to think, well, how can I supplement what they've lost with other things? Moving on to the cultural aspects. So sexuality is expressed in many different ways. Our tendency is to think the way I do it is the normal way and that everybody else does it the same way. And that's not true. And we are a very multicultural society these days. And it's really important to sit back and let your patient or client tell you how they see sexuality, why they see it as a problem, or what they want to do about it, and not to project onto your patient. So sometimes I have to sit on my hands and close my mouth and not want a better sex life for my patient than they want for themselves, because it's about them. But there are huge cultural differences, and we need to be sensitive to them. If I had more time, I would tell you some more stories about how I learned about all of that, but I can't give you all the information in 1 hour. So it's normal to find it hard to talk about sexuality. As health professionals, we are just like everyone else in society. We grew up in similar families of origins where sexuality was perhaps not talked about, or it was talked about in a very clinical, functional way. Most of we learned, you know, by flying by the seat of our pants, as it were, through our own experiences, good, bad, indifferent. But we didn't get taught how to talk about sex. And we certainly didn't get it in medical school. So don't feel uncomfortable about the fact that it's not easy to talk about. But if you can really absorb the fact that it's so valid in people's lives, especially in our society where even toothpaste is sold with sexuality, where all the reality shows project that everyone is hypersexual and finds it really easy, then you come from a position of strength, because you're talking about sexuality not for your own interest, but because you're interested in the well-being of your patient, and they will love you for it. Because as we all find it difficult to talk about, I think, you know, it comes down to it's the health professional's role to initiate that dialogue. And, you know, I've said, you know, we find it hard because everyone assumes it's natural. And one of the things I hate most is when my patients come in and say, I want sex to be natural and spontaneous. And I think, oh my goodness, you know, nobody wants natural sex. We all want recreational sex. And, you know, how can you be spontaneous in a busy lifestyle? You know, people say, well, I want sex the way I had it when we were first courting. Well, I say, well, how did you go about it? Well, we talked on the phone for hours, validating each other. We planned nice activities that were on our best behavior to enjoy. We usually had foreplay for, you know, half an hour, or whatever. And we had great sex. And I say, well, what do you do now? Well, we put the kids to bed, we take out the garbage, we, you know, argue about, you know, how much money we have, and we hop into bed at 11 o'clock at night and, you know, we start. Okay, can you see where the problem is? So spontaneous sex, natural sex is not what you want. We have to be intelligent about the way we make love, especially if we want to have good sex in a long-term relationship. If you look at romance books and romantic movies, they're all about meeting, about new relationships. And we get very little realistic education about how to maintain good sexuality in a long-term relationship. So it's our responsibility to bring up the sexual agenda. That's the system. So there's the patient and the client, there's us, but we have to remember the partner because they bring in their pluses and minuses into the interaction. And then there are the societies and institutions that also, you know, in schooling, what happens in nursing homes, what happens in care homes, how that is all affected, and how doctors and nurses and OTs and physiotherapists relate around sexuality. So what are the barriers for the client? Well, mostly they're embarrassed and ashamed because they think that there's something wrong with them, because somehow everybody else is having this fantastic sex and what's wrong with them that they can't do it. With this important condition, whether it be MS or cancer or some other condition that's serious, they usually think that somehow it's not important enough, because if it was important, the doctor or the health professionals would raise it. And we tend not to, so that the patient feels that the issue is not so important, and they can't waste the doctor's time. Sometimes there's shyness about revealing an intimate aspect of marriage, or they don't want to reveal partners' problems or inadequacies. So that's just a brief overview. For the partner, it can be the fear of being thought selfish. Here is my partner going through the crisis of having MS, of having MS episodes, and I want to have sex. So they hold back. Unfortunately, that has consequences. It can be fear of hurting the patient, or fear that somehow they're doing something wrong, or they can make the patient, the person with the MS, worse, or have some effect on it. So they will hold back. But then think about your own components, and this will not be the same for everyone. So I assume that if you've been interested enough to listen to me, that in fact you're probably quite knowledgeable and experienced. But even if you're very experienced, there will be variations in the way that you treat different patients. So have a think about it. If you're, for instance, a young female doctor or a young OT, and you get a young man coming along to talk about his sexuality issues, how will you respond to him as compared to an older man? Will you treat them differently? So it depends on your own gender and the gender of your patient. It depends on your age and the gender and the age of your patient, and also what life stage you're at. So if you're young and enjoying a vibrant sex life, your attitudes will be different to perhaps if you're older, if you're separated, if you're alone, if you're not well, or if you have problems in your own sex life or relationship. So we have to be very careful of especially the last one. And I brought that up with looking after yourself, because when you're dealing with sexuality and very intimate aspects, it can trigger our own feelings. And if you're vulnerable, so if you've got sexual difficulties yourself, if you've got relationship difficulties, if you're recently divorced, or if you're depressed, it's really important that you seek some supervision and guidance so that boundaries don't get blurred. So one of the issues that health professionals have is, will I be inappropriate? And if you have clear boundaries that what you're doing is for the client's or patient's benefit, and you've got a boundary around your own sexuality and your own issues, then you won't be inappropriate. But the health professionals who get into trouble are where those boundaries have been porous, usually because of their own needs. Opening a can of worms, and I won't be able to deal with the situation. I will stress again and again that the most important thing that you give your patients around sexuality, not so much even information or specific instructions. What you give is the validation that their problem is valid and that it's worthy of attention. So if you can open that can of worms and just validate that it's valid, and then you can either refer or whatever. If it's not your area of interest, or you feel you don't have enough skills, then you will have done a wonderful thing. On the flip side, if a patient has gotten enough courage to bring up the issue and you're uncomfortable and you shut it down, the chances are they'll find it very difficult to open up again to another health professional. So you don't actually have to be interested in this field of work or know a lot or spend a lot of time subsequently with dealing with it. But if you can validate that it's important, then you've done a wonderful thing. And then if you want to go further, then you can upskill yourself and designate more time for the patient, what have you. So do not worry about opening up this can of worms. You don't actually have to deal with it. You just have to validate that it's important. So we do need a certain level of comfort with our own sexuality in order to be able to interact with our patients appropriately, because we give ourselves. It is a different area of medicine than hypertension or even dealing with the practical aspects of MS. So it's important to be genuine, and it's important to know your own personal ways of avoiding sexual or difficult discussions. And these can be verbal or non-verbal. So just reflect back, to a situation perhaps where you haven't been totally comfortable, and how have you dealt with that? Do you deal with it by picking up a pen to write some notes? Do you distract onto another question without really giving the patient enough time to answer the previous question? Do you fidget? Like, will you move in your chair or cross your legs? And the most subtle of all is dropping eye contact. The patient who's anxious or presenting something to you that's making them vulnerable will be watching you. And if you drop eye contact at that point of embarrassment or insecurity, they will pick that up and then they will shut down. So it's really important to know yourself and how you react when you're uncomfortable. So to be comfortable about inquiring about sexuality, be comfortable with your own sexuality. Give it some thought. Think about your own family of origin, what kind of education you've had, what experiences you've had, and own them. If you've had an unpleasant experience, and I'll just give an example. I'm sorry if it's personal for some people, but perhaps if you've been raped, that doesn't necessarily make you an expert for dealing with patients who've been raped. You have to keep your own boundary for your own experience and explore the other person's experience, because it may not be the same. Understanding all those gender and cultural differences, and also around ability and disability issues, what comes with that. Being comfortable with sexual language. And often part of the difficulty patients have is that they have no language. They'll tell you that, they have problem with trumpeter. And, sometimes I have to stop a bit and catch up with, what do they tell? Their penis or Peter or Willie. If you think about the kind of words we have in our culture that describe sexual bits and pieces and behaviors, the more words we have, it's a reflection of our discomfort with it. And it's about mirroring the client's verbal and non-verbal language so that we build up a kind of a twinship with the patient. And that's where comfort for both of us arise. And gradually, with time, perhaps you might want to teach your patients words that you're more comfortable with. Like, I don't mind saying the word fuck, or, someone's having a bonk, or, some of the more colourful words even that some of my patients come up with. But I prefer to use my own slightly more conventional words. But becoming comfortable with that language is very important. To actively educate ourselves with sexuality. And there's so much material out there now, and so many courses, family planning associations, for instance, that you can upskill yourself. And it's really important to think about the environment. So you can't do sexual work quickly. It does take time. People often sit there ruminating for a few minutes before they can come out with what they actually mean, and to explore the nuances of their experience takes time. So it does take a prolonged consult, that's 45 minutes to an hour. You have to have privacy. You can't have your secretary coming in. You need to give that respect and that privacy and that confidentiality. And I'm very aware that often for country practices, that's very difficult, because your secretary might be the next door neighbour or the nephew or the niece, or know someone that's, you know, in the community. And it's often difficult for the patients to socialise with the health professionals in their small community when there's been disclosure of this really private, intimate material. So that's a difficulty, and sometimes people in the country do travel long distances. Now with telehealth, that's of course a lot easier, but it is an issue, and to be aware of it. So we communicate with language, and as I've said, that, you know, we usually aren't very good with sexual language because it's not something that we got taught. You know, our parents probably all spent a lot of time teaching us how to eat nicely with a knife and fork, but they didn't teach us how to negotiate when there's a desire discrepancy in the relationship. So, you know, it's something that you have to upskill yourself with. So to become comfortable with bringing sexuality into the consultation, it's important to practice and make it a routine that you included with all your intake patients. So these days I'm asking all my patients with MS about their sexual function as it can be affected. So you're normalizing. It's not just that person who's got a sexual difficulty, you're generalizing it to the whole population, and you're showing caring and interest in asking them. And if you're cool about it, then the way you're presenting the question will be very respectful and non-threatening, and you're not crossing any boundaries. Patients, in my experience and from research, really appreciate when the health professional raises this issue, because it is so hard for them. And with MS, you have, you know, full access to the whole medical condition that can affect sexuality. The MS medications can affect it, the MS condition itself, and then don't forget the partner. So has your partner mentioned that they're having any difficulties that have arisen since you've been diagnosed? So it's about normalizing it, generalizing it, and an open-ended question. Now, if you're a little bit uncomfortable with just introducing it, you might preface this with saying, you know, I'd like to ask you some sexual questions, which can be, you know, intimate or a little bit embarrassing, but it is important for your general well-being. Do you mind if I ask these questions? So you can be respectful and ask. Now, don't be thrown if the patient says, well, I'd rather not. You know, they've got a lot on their plate when they're first being diagnosed. And the chances are that, you know, if you're especially a new health professional introduced into their life, that they will be shy. But if you've raised it, they will put it into the computer, the back burner, and when they're more comfortable or when they're ready, they'll know that you're open to dealing with it. So it doesn't have to be straight away, but if you've tabled it, they will pick it up when they're ready and they want your help, knowing that you're open to it. So I've mentioned this, listen to your patient's language, verbal and non-verbal, and especially explore their ideas on helping themselves. So, you know, what have you been able to do that you think has been helpful? What would you like to try? What would you like to achieve? So you don't have to put all the responsibility and pressure on yourself. You know, your patient and the couple know their sexuality much better than you do at the beginning. So it's about just teasing out their story, what I call the sexual script, and listening to where there are disjunctions, things that don't make sense, and then your help can be more appropriate. But exploring your patient's sexual scripts, and the sexual script is what you do from when you have your first sexual thought to how you engage your partner to have the sex, to what you do actually while you're having sex, to what you do after you've had your orgasm. That's the sexual script. And in listening to people tell you their sexual script, where you're the external person not emotionally involved and it's not about you, you will be able to see things that are quite obvious are causing a problem. And that's where you're going to be most helpful. So when the patient is describing what they're doing, and you kind of quizzically ask, oh, and how does that work for you? Or that seems to be a little bit fast. You know, does that work for you? Or do you think it might be better for you or your partner if you slow down? So taking elements from their sexual script that they're talking about is where the helpful component is going to be. And people love, once people relax, they love talking about their sex life and what they do. But they've often done things without thinking about it quite, you know, in any depth. So in telling you, they're actually hearing their own story. And they can often see where things are perhaps not done for the best. And they will come up with their own creative solutions. So once again, establish that context and that relevance with sexuality. So you will not be inappropriate. And your patients with MS don't just have MS usually. They are normal people in society, and they have the full range of all the other conditions that we have. And all of those chronic conditions have a sexual consequence. So bringing in that relevance will give you should give you the confidence that you're doing something that's helpful. So patients with MS have the full range of sexual difficulties that anyone in the community will have. But some are more exaggerated for patients with MS than you know, people with other conditions or with nothing else. So it's all those effects on libido, altered genital sensations, taking longer for arousal, or whether it's lubrication or an erection, difficulty reaching an orgasm or not having orgasms, that decreased lubrication, which is that female equivalent for arousal, and for the males, difficulty with erections, and that changes in ejaculatory response, whether it's faster or slower. And all of that, of course, correlates with all the MS signs and symptoms that you can have, plus that added burden of depression. You know, being diagnosed with MS is a life-changing event, and depression is really common, and depression in itself and the treatment for depression has sexual consequences. So all of that needs to be explored and taken into account. So if you're dealing with sexuality in general practice, this is just a little schema of how you might progress. So whether the sexuality issue is driven by you, so you raise it because you're screening an at-risk patient. So with the patient with MS, you know that MS has a higher burden of sexuality problems. So of course you're going to screen them for sexuality. If it's patient-driven, there might be various presentations, and to be very aware of that out-the-door question. And it's so frustrating because you've spent your 20 minutes or 45 minutes, and you're shutting things down and preparing yourself for the next patient, and the patient, oh doctor, then this has happened. I did mean to tell you I'm having a little problem with Peter or Pecker or whatever, and you think, oh, what do? You must validate it, and you'll say to your patient, oh, I'm really sorry we've run out of time, but this is such an important thing that I'd really like to explore with you to see what we can do about it. Can we make another appointment, and usually a prolonged appointment? So just acknowledging that it's a valid question, that you're interested and you want to help and bring that patient back is what needs to be done here. Being aware of reading between the lines about these vague hints, intimacy problems, or my partner's not so happy, vague things that don't use the word sex in it, so that you can address the issue. So if it's you're driving it and the patient has said no, leave the door open to come back again. If it's yes, then usually make start exploring with a good sexual history. And I would recommend that you Google, taking your sexual history, so that you've got a script for yourself and you start practicing it, and it becomes normal for you, going through the questions of, what is the situation, when does it occur, when did it start, is it better sometimes, is it not better, but, having a standardized interview questionnaire will help you if you're starting out on this. Inadequate time, show interest. And if you show interest, you've already done a wonderful thing and probably really decreased the anxiety that the person is feeling. Ask about the partner. Ask about involving them, because you'll quite often get a different story as well. And reschedule for a long appointment. That adequate time is so important. So it's taking that comprehensive psychosexual history, the medical, including medication, surgical and psychiatric history. Physical examination may be important. Blood tests, I showed on the previous, diabetes has a high loading of sexual difficulties. And your patient with MS could have diabetes. Cardiovascular examination, if you're a GP, I don't need to go through all of this. Then having someone in your community whom you know is interested in sexuality, whether it's a psychologist, it could be a social worker, it can be a counsellor, and some OTs these days are interested in sexuality. It may be another GP in the area. It's really important that you take this seriously, because in Australia, we don't have accreditation or registration for sexuality, for sexologists, which means that almost anyone, you can be a plumber and you can put a shingle out to say, I'm a sexologist. So there's a potential for causing a lot of harm for our patients going to self-professed experts. In Australia, we do have the Society for Australian Sexologists, which is our national organisation now, and in New South Wales there's ASSERT as a state organisation. And the organisation is pushing for accreditation, so we've got internal accreditation within the organisation to try to get that professional aspect going. But So you can also always go onto the website and talk to whoever the state president is to see if there's someone in your area that is known to us, sorry, who can help you. But if not, then if you hear that, say, someone is practicing near your practice and is interested in sexuality, give them a ring. Find out what their training is, you know, what the outlook is, so that you can be confident when you refer your patient to them that they're going to get good care. Because it is a kind of a grey zone with who is a sexologist or sexuality expert, and you know, how they will treat your patient. The most important thing is a history. And if you're a GP, then you're good at taking a history. So, you know, as I've said before, acquaint yourself with the questions you need to ask to explore the sexual script, and start practicing it so that you're comfortable. I've been doing this now for 40 years, so I am comfortable. You know, I do ask people really intimate questions like, how do you masturbate? And they sort of look at me and say, you know, like everyone else. And I said, no, everyone's an individual, you know. And I talk them through what they do, because I know that what we call idiosyncratic masturbation can create difficulties in a relationship. And, you know, so I'm comfortable with exploring really intimate aspects of people's sexual scripts, how they do things, when they do them, why they do them. It just takes practice. I wasn't unembarrassed at the beginning when I started my career as a sexologist. But if you really hold that line that I'm asking these questions because the information gives me knowledge which I can then use for the management or treatment to help the patient, then you'll be doing the appropriate thing. If you're just collecting information for the sake of collecting information, then it's not appropriate. So our patients with MS have that added burden of sexual difficulties beyond the average in society, and their partners share these added losses. So as a health professional, we're in a very privileged position to help prevent or minimize the losses. So quite often, we can't give people back the sexuality that they had prior to their illness or 10 years younger. But we can minimize the losses with, especially these days, there's wonderful medication, there are wonderful toys that we can suggest. So it's about knowing about all of those and being able to use them appropriately, because we know that patients suffer in silence as they assume that if sexuality and intimacy were important, health professionals would discuss them. We're so comfortable. We ask people, you know, have you pooed today? Did you have diarrhea? Were you constipated? How often? The consistency of it? Was there any blood there? Was there any mucus? We don't blink. Why should sexuality be different? We are all sexual beings. Sexuality is normal. And, you know, gradually we can bring that into our practices. So going forward, because I've just given you a taste, I'm very aware that, you know, just this lecture hasn't made everyone a competent sexologist. It's a starting point. If you really feel in your heart that it is important and it will add to the well-being that you're giving your patients, but work to your own level of competence. Because one of the danger signals is, you know, or points is actually working beyond your level of competence. And one of the interesting models is the PLISSIT model, which you can Google, which takes you through, you know, exploring, validating, giving limited information, then, more intensive therapy, and then referral. So you can find your own level of comfort and competence and work to that level. Look up, sexual histories, how to take a sexual history and what's included in a sexual history, and practice it so that you become automatic and comfortable with it. Be aware that there are psychosocial and medical aspects to each sexual difficulty. A man might have a vascular problem causing his erectile difficulty, but he will have psychosocial aspects as a result of or compounding that medical issue. So you do have to be comfortable with both. One of the things that the PDE5s, and when Viagra came on the market, it really changed the sexual field, and I got a lot more patients. And the reason for that was that GPs thought, oh, here's this fantastic medication, and it is fantastic medication, and comfortably gave it all to men. And the men would come back and say, I've stopped using the medication, or it wasn't successful, or whatever. And the reason is that helping the man get an erect penis didn't change the sexual habits that had already developed in the relationship. So just because the man suddenly presented to his partner with an erection didn't mean the partner was interested in having sex with them. And you have to deal with the relational, the social aspects, and not just give medication. But the medications and the aids and the toys we have these days are really lovely. So there are management options for all the sexual difficulties. There is no sexual difficulties where you can't have some benefit. And if you're not comfortable with that, then to have that good referral network with people you trust. So just to start summarizing things, because I'd like to leave a few minutes to questions. Raise the sexual health at the intake. And the reason for that is that if you ask sexuality questions later on, people usually attach the sexual problem to either the onset of MS, to the medication, to the change of medication. And they're usually not aware of that gradual evolution of sexual difficulties. So if you can take that sexual health history at intake, you take it again, or you just revisit briefly at the initiation of any medication, at the change of medication. And you review it with changes and fluctuations in the MS, so that you can keep abreast with all of that. And I can only say that your patients will love you for showing that interest. But do refer if it's beyond your interest level. And there are so many references and resources I can give you. The Healthy Male has wonderful material on it. The Jean Hale's website has lovely material on it. If you want to talk to anyone, make contact with whoever is your state president at the Society of Australian Sexologists, and we're all very willing to help colleagues to talk through perhaps a case or a difficulty you're having, not necessarily even to refer to somebody else, but to help you manage it. And there is some research that shows that patients actually prefer their primary health physician to deal with their sexuality issues, as opposed to being referred to a tertiary person. So, all of us are very happy to help colleagues actually manage their own patients. These are just some of my favorite authors. There are so many. Bernie Zilbergeld is Men and Sex is a classic, but that information is still good. Rosie King, our own Australian Rosie King, has written some lovely books. They're really practical that you can read and you can give to your patients. David Snash is an American psychologist who's a little bit difficult in his language, but I love his book, Passionate Marriage, and he talks about us taking responsibility for change. So people often want to be different, but don't want to invest the effort and the time to change. And he addresses that. So, and he's got some lovely suggestions in his books as well. So if you can be prepared to read his language, his use of language, I think is good value. You can Google the Clifton model, which is, freely available, and the Society of Australian Sexologists. I'm a member in New South Wales, but I think all our state presidents are lovely and very helpful if you need any further help. And I'd really love personal questions, because then I can address something that you're really interested in rather than what I thought I would present, because ultimately what we want is wellness in our couples. And I do believe that as mammals, interconnectivity and sexuality is a very important component of that, is an important component of wellness. Thank you.
Thank you so much, Margaret. I really love the sensitive way that you put across the whole conversation about sex and sexuality with our clients. And I'm hoping that our listeners are feeling much more empowered now to start that conversation. I have got a couple of questions just in the last minute that we've got left. Jane's asked about where she might find information on taking a sexual history. And I know we've talked about the possibility of doing a webinar on this, Margaret, if you're still willing to, after your experiences today.
Well, taking a history there's an individual component, that works with your personality, but just Google it. Taking a sexual history. I very quickly Googled it when I was preparing, and lots of really helpful sites come up just to look at. And I'd be very happy to do a webinar on taking a sexual history as well, if people think that would be helpful.
Fantastic. I will get back to you on that then, Margaret, once you're still feeling brave enough to do that. And Bridie's asked, do you have any resources on incontinence and sexuality?
That's an interesting one, because I was actually asked at one stage by one of the sanitary products people to do something on that, because it is a huge problem for women and a huge source of embarrassment. I mean, being continent is part of being an adult, and I think when adults become incontinent, there's this kind of infantilization, and then you don't feel very sexual. And also about the odor and the hygiene. So once again, I'll just Google it, or if you want, I can look up some of my references and email them to you, or send it in. I usually talk about the fact that urine is really a sterile product, that it causes no harm, and about including it. So if you can't treat it medically, if doing pelvic floor exercises haven't been helpful, or you're not suitable to have surgery to correct the issue, then it's about acceptance. And the acceptance can be using like a cot liner underneath you. I talk about using nice colourful towels over that with ribbons and frills. So to be able to include the incontinence component into the lovemaking without making it a big deal. The other thing can be, I talk about outer course a lot with my patients. That at what point is the incontinence intrusive? How can you minimize it? You know, of course, emptying your bladder before you start lovemaking and cutting down on your fluid intake, perhaps for the couple of hours before you plan to make love. Those are the kind of things that I talk about. Yeah, men also now with radical prostatectomies can have continence issues. To some extent, it doesn't seem to be as big a problem because men are used with ejaculation, that there is a product that comes out. It's about volume, it's about odor, but it's that subjective response, I think, that we have, that we're not adults if we're incontinent, and that our partner will be repulsed, and about exploring that in the relationship. Is the partner repulsed? What does it mean to them? Those kind of issues.
Thanks,
but
Margaret.
If you want me to send through some references or some resources, I'll have a look to see what I collected before.
Thanks, Margaret. If you do send those references, I will send them out to all our attendees. And just got a couple of other quick questions. Juliana's asking, do you have any resources for people who aren't in a relationship or who aren't in the usual heterosexual cisgendered relationship?
Okay. The easy thing is, for me, relationships are relationships. So, the sexual orientation for me is not such a, it's not an issue. For people who aren't in relationships, I think it's really important to talk about sexuality and, good masturbation. Masturbation has a very bad press in our society. So you're not supposed to do it, and it's private, and you're naughty or bad if you're doing it. And I tell people that I think masturbation is the best thing since sliced bread. It's there's no harm that comes from it. You get it's not quite the same as somebody else caressing you, but at least you're touching your skin. You're being sensual, and then touching your genitals. That self-love component, and to make it fun. So with people who don't have partners, I've spent a lot of time about talking about how to make masturbation fun, using all your senses to have variety and creativity, and to give yourself permission to enjoy that sexuality aspect, because I think it is very important. And if your patients are getting older, then I very much talk about the fact that if you don't use it, you'll lose it. I talk about that. I talk about websites for toys to help yourself. That's what I do. Now, if there are resources, the only one that comes to mind, Betty Dodson from America wrote a book called something Sex for One. But I can't offhand think of any, resources that are specific for that, but I can have a look, and I'm happy to send them through if I find something that I think is good.
Thanks, Margaret. And also, we do have a podcast that you did for us, Margaret, that is based for our clients, where we've got some links to toys that people might use and some recommendations there, and also some information about pelvic floor exercises, along with a whole discussion that we had around sex and sexuality. So encourage our listeners to have a look at the MS podcast area on our website, ms.org.au, or look up MS podcasts on Spotify, and there's a lovely podcast that Margaret did for us there. So I will bring this to a close now. This is a subject, obviously, that we could talk about forever, and I can see that everybody is still all online, Margaret, so you have, as always, captivated the audience.
Thank you, everyone, for staying online.
And people are all sending in their thank yous as well. So,
all right, thank you.
So I just want to finish off finally just with very briefly some final housekeeping slides. So just bear with me, guys, whilst I take back the screen. Just want to very quickly point out that we have a range of services available for you and your clients. So there's education, there's peer support. We're doing a lot of work in the NDIS space. There's employment support, etc. There's the MS Practice, which is an online education tool to support allied health professionals. We are an NDIS provider providing different services in different areas. You can access your free ebooks. And we have a MS shop with our recordings of webinars available to you. And we have a newsletter with all our upcoming education that you can subscribe to. So the gateway to all our services is MS Connect 1800 042 138. And thank you very, very much for your time today. We really appreciate you coming and wish you luck starting these new conversations with your clients. Thank you.